So we're going to finish with a couple of case presentations, and we're very grateful to those who've submitted these. This is really just to give people an opportunity to present and to generate some discussion points. So again, we want to keep this informal with lots of questions coming through. So I think the first presentation we've got, and please forgive my pronunciation again, especially done in a Geordie accent, some of these pronunciations are a bit challenging. So I think we've got Yewande, Adegeye and Dr. Puffett presenting on VTE in an acute setting. If we can check that they're here and that they're ready to start, please.
Yes.
Brilliant. And I hope I wasn't too far off on your name.
No, you are not. All right, I'd like to share my screen now.
Yes, that's fine. We'll let you know when we can see them, then you can get started. Thank you very much.
Can you see my screen?
Yes, we can. Thanks very much. We'll let you get started.
Okay. So I'm a junior doctor in one of the health boards in Wales, and I'll be presenting this case of pulmonary embolism and one of the complications of treatment in one patient we saw. I know we've heard a lot of information already today about VTE, so I won't bore us with all of this, but just to refresh, VTE encompasses pulmonary embolism and DVT. And we're very familiar with this term because most often when we have patients who come into hospital, we need to put them on VTE prophylaxis to prevent clot formation on admission. And it's seen as the third most common cardiovascular disease after myocardial infarction and stroke. And we know what happens in PE is that there's a thrombus which usually forms in the veins and mostly in the veins of the lower limbs. This then dislodges and goes to obstruct the pulmonary system, causing some severe dysfunction. And it does cause a lot of morbidity and mortality. So this patient I'll be presenting was a 32-year-old obese lady who came in with fever, pain, and swelling in her right thigh. She then described some chest pain she had, which sounded pleuritic from the description, and she was quite short of breath. She had no significant past medical history. She wasn't on any routine medications. From her social history, she was smoking 40 sticks of cigarette a day, and she's been smoking for over 20 years. And she also uses quite a number of IV drugs, from heroin to cocaine. And of course, when we saw this, it was ringing a lot of bells of thrombosis everywhere. So we went on and examined this lady. She was tachycardic at 114. She was pyrexial, and she was saturating at 78% in room air. The chest examination revealed reduced breath sounds bilaterally. And on the right thigh, there was this really big abscess with surrounding erythema. The rest of the system examination was fine. At this point, we sent for some investigations, both imaging and bloods. We did a full blood count. This showed pancytopenia, and the CRP was elevated at 314. The UNAs and LFTs were normal. Our D-dimers were over 20,000. Our blood culture was positive for MRSA. We did a blood gas, and she was in type 1 respiratory failure. And of course, we went on to request the first-line imaging for suspected pulmonary embolism, which is the CT pulmonary angio. And this then revealed a right-sided pulmonary embolism with basal atelectasis. And at this point, of course, we made an assessment of type 1 respiratory failure, secondary to the pulmonary embolism. She had this right thigh abscess, which at this point must have then caused some septicemia already with the MRSA, and then may have led to the pancytopenia. And of course, there was some element of pneumonia. COVID being at the center of everything in the last 1 year, we thought the blood picture may have been a result of vaccine, but we then subsequently dismissed this because she hadn't taken any of the vaccines yet. And going on to manage this patient, she definitely needed some oxygen because she was saturating at 78. And even on commencing oxygen, she was still saturating at less than 19% on 10 liters. So we got in the HDU team to come and review. And after review, they deemed that fit for intubation and mechanical ventilation. And so she was then transferred to the ITU. We gave her some IV fluids. She was on antibiotics because of the sepsis. We had to drain the abscess and dress with some antibiotics. and give some blood transfusion. Now, the first line for managing VT now we know is DOAC. And in this patient, we couldn't go ahead with that because at some point she was on rifampicin, which is an enzyme inducer, and the hematologist advised it would not be the best option, either the DOAC or the warfarin. And so the best would be to start her on some enoxaparin, which we did. And then she was in the HTU for about a week, and subsequently she was out of type 1 respiratory failure and stepped down to the ward. But then she had a complication of our treatment. She had a massive hemorrhage. So I'll just quickly run through the progress of this patient. She was in the HTU, like I mentioned, for 1 week and then stepped down to the ward. And then a few days after that, there was a med call put out for cardiac arrest on the ward she was on. And we went in there and it was a massive hemorrhage everywhere. The ITU team came in. She had to be intubated again and taken back to the ITU. She had blood transfusion with both Pacra cells and fresh frozen plasma. So she was in the HTU again a second time, and subsequently she was stepped down to the ward again. And since we're considering discharging her, she had to be educated on what she had had, which was the pulmonary embolism. These risk factors that may have put her at a risk of developing this pulmonary embolism, which would include the smoking and the her weights. And so she was educated on this. And because she needed to go home and Clexin, she was also educated on how to self-administer the anticoagulant, and also to be followed up by the hematology team and the drug and alcohol service. And the reason for the follow-up with hematology is for a likelihood of conversion to DOAC at some point after having Clexin for a while. So this has been spoken about today by the consultants who have spoken earlier, the VENOUS triad, which kind of gives an idea of some of the mechanisms that work together to put people at an increased risk of thromboembolism. And in this patient, she had quite a number of risk factors for pulmonary embolism. And right from the symptoms she presented with, pulmonary embolism was very high on the list. She was obese, one with obesity has been described as a chronic inflammatory condition with release of some procoagulants, and that will cause some hypercoagulability of blood. With IV drug abuse, that causes some endothelial damage. And with smoking too, smoking has been seen also to damage endothelial lining, and at the same time, change the surface of platelets, making them clump together. So in this patient, she had quite a number of risk factors for PE. So in summary, I have described pulmonary embolism in a young patient who had quite a number of risk factors, and pulmonary embolism on its own causes severe respiratory dysfunction and can have complications both from the disease itself and from the treatment, just as we have seen in this patient. So understanding the risk factors for possible pulmonary embolism can aid in prevention as well as making appropriate diagnosis in order to treat the patient. Thank you for listening.
Thank you very much. It's a common clinical dilemma that we have, somebody with a blood clot who also at high risk of bleeding or has had an acute bleed. And certainly that's the kind of thing that I get called about very frequently in attending weeks. What was the eventual diagnosis in terms of the reason for the abscess? Was that felt to be related to her use of intravenous drugs, or was there an underlying unifying diagnosis for that and the pancytopenia?
So it was more of the injection, because apparently she had been ill for over 5 days before presenting to the hospital, but that didn't stop her from injecting the IV drug. So the abscess was more from the injection. Yeah.
Yeah, and I'm sure lots of us on the call will recognise that giving ongoing anticoagulation in these patients is really challenging. In patients who are drug dependent, in terms of compliance with ongoing management and risk of future thromboses, even if they are provoked. There's a question on the chat asking, what was your decision for long-term management? So I presume that relates to long-term anticoagulation and whether this patient went on to have that.
So the plan for her was to continue on Clexane when she left hospital because she had had rifampicin, and the advice from the hematologist was because she's had rifampicin, she probably need about 4 to 6 weeks after stopping rifampicin to consider a change to DOAC. So the plan is for her to continue Clexane, and then she'll be followed up in the hematology clinic.
Okay, that's great. We'll just give it a couple more minutes to see if anybody else has any questions to put through on the chat. Just check the Q&A box as well. So we've got a couple of questions on the Q&A box about the nature of the bleed. Was it a haemostasis or a GI bleed?
So it ended up being haemostasis after we took a history. And then I think when she got stable, we ended up doing an OGD and there was no obvious source of bleeding. So it was agreed that it was haemostasis. Okay.
That's great. Thank you very much. Very interesting and very nicely presented. So the next presentation is from Michelle Currie and Dr. Meena Khandelwal from Cooper Medical School in New Jersey, and this is about clot management in a pregnant patient with May-Thurner syndrome. So if we can just check that Michelle is here and then allow her to load her slides, please.
Hi, thanks. I'll share my screen now.
Thank you. That's
okay. Can you see my slides?
To you, Michelle. Thank you.
Thank you. Good morning, good afternoon, everyone. Today I'll be presenting on clot management in a pregnant patient with May-Thurner syndrome. I'm a second-year medical student along with Dr. Meena Khandelwal. So the goals of our case report today is to recognize May-Thurner syndrome as a risk factor for deep vein thrombosis. Secondly, to understand the overlap of signs and symptoms of venous thromboembolism in post-thrombotic syndrome. And thirdly, to understand the complexity of management in deep vein thrombosis in pregnancy. So the case today that we're going to discuss is about a 28-year-old female. She's had 3 prior pregnancies and she's currently pregnant at 32 weeks gestation. She's had multiple admissions to the hospital for complaints of worsening leg swelling and pain. And a thrombophilia workup has been done and came back negative. So going back to her first pregnancy, there was no complications in 2012. Then in 2016, she became pregnant for the second time, and she presented with left leg pain and was diagnosed with superficial thrombophlebitis. She was treated with anticoagulant in the hospital, and then she was discharged without prolonged anticoagulation. Also to note at this time, her BMI was 35, which we're assuming is an increase from her first pregnancy in 2012. So later that same year, she's 5 weeks postpartum, and she presents with left leg asymmetric swelling, and it's worsening. And since she's postpartum, we would expect the swelling to be going down. She shows 2+ pitting edema. There's pain on the posterior medial aspect of the leg, and imaging studies showed extensive progressive thrombosis of the great saphenous vein within 1 centimeter of the femoral vein. So the patient was fully anticoagulated with rivaroxaban for 6 weeks, and then she discontinued the treatment due to vaginal bleeding. In 2017, due to continued episodes in the hospital for swelling and left leg pain, a CT pelvis with contrast was done to confirm the diagnosis of May-Thurner syndrome. So May-Thurner syndrome is an anatomic anomaly, and you have compression of the left common iliac vein by the right common iliac artery where it crosses over. In addition, there's compression at the junction where the external iliac vein joins the common iliac vein. An ultrasound guided stent was placed in the common iliac vein across to the external iliac vein to keep that vein open and to hopefully alleviate the pain and the swelling. Also at this time, she was placed on a prophylactic dose of low molecular weight heparin. In this case, it was enoxaparin 40 mg per day. Here is a diagram of where she had the SVT along the great saphenous vein. And because it was within 1 centimeter of the femoral vein, she was fully anticoagulated. In 2017, after the stent was placed, there was no improvement of the leg edema, but the pain did improve. And at this point, she developed a post-thrombotic syndrome. So there's hypopigmentation of her leg, 3+ pitting edema. A CT venogram confirmed there was no DVTs. And on physical exam, you could see palpable cords and varicose veins. At this point, because the swelling wouldn't go down, the decision was made to do an endovenous laser therapy to ablate the great saphenous vein. She returned to the hospital several times for leg pain and swelling throughout 2017, and there was no signs of DVT, and she was given prophylactic dose of enoxaparin. In 2018, during her third pregnancy, a DVT was found in the left femoral vein at the proximal and mid-level in the first trimester. An ultrasound confirmed the DVT, and it also was confirmed on CT venogram that her stent had remained patent. The patient was fully anticoagulated with IV unfractionated heparin, and then when she left the hospital, she was given a adjusted therapeutic dose of low molecular weight heparin. However, she continued to show symptoms of post-thrombotic syndrome, which was that swelling, pain, varicose veins, and hyperpigmentation of her left leg. Currently, she's on her 4th pregnancy, and she continues to show to the hospital for episodes of leg pain and leg swelling. And because of this, an IVC filter was placed to try to alleviate these symptoms. And then an added benefit of IVC filter is that if the stent tends to migrate, if the stent does migrate, the IVC filter can stop it from moving past into the heart. So she's currently pregnant, and she continues to present with lower left extremity pain and swelling. Here are ultrasound images of the DVT that she was diagnosed with in 2018. This is an image of the left femoral vein at the mid-level, and we can see the DVT is noted here. And then the left femoral vein at the proximal level, and the DVT is noted there. Also, Doppler imaging showed the left popliteal vein there's no flow present. And then for comparison, in the right common femoral vein, flow was still present. And then another image, this is still from the DVT she was diagnosed with in 2018. This is of the left femoral vein, and you can see here where there's no flow is where the DVT was. So what is May-Thurner syndrome? It's a congenital anatomic anomaly of the right iliac artery causing a narrowing or compression of the left iliac vein. And you can see on this diagram, this dark is the vein, and where the artery crosses over, you can get compression in this area. So this predisposes patients to proximal deep vein thrombosis due to deposits of intraluminal collagen and slow venous flow. Typical clinical presentation can come up a few different ways. You could have venous compression and the patient will have no symptoms, or they could be symptomatic with left leg pain and edema, spur formation, which is due to that intraluminal collagen depositing in the veins. And most commonly, May-Thurner syndrome is diagnosed after a DVT is found in a patient. So challenges of differentiating a DVT from post-thrombotic syndrome can be difficult because the symptoms really overlap. Typical presentation of a DVT is swelling, pain, warmth and redness in the involved extremity. Post-thrombotic syndrome typically occurs in 40% of patients who had a DVT, and those symptoms will include dependent swelling, discomfort of the affected limb. So in severe cases, it can lead to venous ulcers as well. Diagnosis of recurrent DVT is complicated by prior DVT with post-thrombotic syndrome because of these symptoms. Other venous disorders are similar, and it can kind of hide an acute DVT presentation that could be coming up. So diagnostic testing and imaging is needed to confirm the reoccurrence of a DVT. So in our patient's case, challenges included multiple and frequent imaging studies that were done, ultrasounds, CT scans, every time she presented with an episode of left leg pain and swelling, because it was hard to differentiate whether this is a recurrence of a DVT or this is just symptoms of the post-thrombotic syndrome. In addition, management of the patient was being done at community and tertiary hospitals. So there's a lot of data on the patient. There's inconsistent histories, and it's hard to follow a common history of since she's been diagnosed with May-Thurner syndrome. So we would really advocate, and our patient would have benefited from a single thrombosis center to manage this person's case, to keep a consistent history, and it would have prevented multiple admissions to the hospital and multiple imaging studies. And then managing deep vein thrombosis in pregnancy is important. Pregnancy and postpartum increases the risk of thromboembolism by 4 to 5 times. And a VTE is one of the leading causes of maternal mortality in the US. Imaging studies are limited in pregnancy due to the fact that you want to limit radiation exposure, radon exposure, and then limiting information on direct oral anticoagulants and anti-factor X inhibitors during pregnancy. So typically the drug of choice is low molecular weight heparin, followed by unfractionated heparin and then warfarin. Low molecular weight heparin doses should be increased in pregnancy as well due to increase in maternal blood volumes and an increase in renal excretion of low molecular weight heparin. You're going to need a higher dose to see the same therapeutic effects. And it's also recommended in pregnancy to have to monitor anti-factor 10A levels per trimester. And then the target therapeutic range is listed here. So thank you for listening. I hope everyone took away, what May-Thurner syndrome is and how it can predispose to DVT, that it's difficult to differentiate DVT between post-thrombotic syndromes due to the overlapping symptoms, and some overview on the management of DVT in pregnancy. Are there any questions?
Thank you very much. I think, again, we can all identify with patients who have bad post-thrombotic syndrome and end up in the cycle of getting further thromboses and worsening symptoms of the PTS, then complicated by pregnancy. This definitely sounds like a very difficult case to manage. So there's a question that's come through asking if there's any evidence that iliac stents or prophylactic IVC filters improve outcomes.
I don't know if it improves outcomes, but it will prevent some, if the stent were to migrate, it's not going to go past the IVC. So, and in pregnancy, it's really hard to visualize the stent due to you want to keep the imaging studies low, and you have to do a CT venogram. So you want to limit the imaging studies that are done.
Okay. And then a question asking, how was information and support shared with the patient?
So she has doctors close to home that she works with, and then when she gets moved up here, information is shared in person through her file or online through her EPIC history chart.
Yeah, and there are some specific queries that tend to come up in pregnancy, aren't there? Because pregnant women will often ask about the safety of medications in terms of the baby and management of delivery. So there's quite a few specific things to think about in this kind of scenario as well. Raza, did you have a question?
Yes, thanks, Jill. But firstly, Michelle, can I just say, great presentation for a year 2 medical student. If you do develop a future interest in thrombosis and you fancy coming to the UK to do some work or research, I'd be very interested to have a conversation with you in the future. That was a great presentation. May-Thurner's in itself is a challenge, and the use of stents, we're doing it with our interventional radiologists. These stents were obviously devised and developed for older patients with vascular disease. We don't actually know if these stents will last the lifetime of the patients, and we worry about stent thrombosis. I was interested that your patient's recurrent events, the stent remained patent, and so I suspect this lady's got a prothrombotics condition, even though we can't identify it in the laboratory. Have you kept the patient on some form of anticoagulant long term now, and if so, what?
Yes, long term she's on enoxaparin. And typically right now, since she's pregnant, she's on a therapeutic dose of enoxaparin long term, 120 mg per day.
So outside of pregnancy, do you think her long term anticoagulant will be low molecular weight heparin?
I'm not sure.
So She's allergic to warfarin.
Yeah.
So probably would be used a DOAC.
Yeah. So yeah, thank you. I was going to say, so we're beginning to develop some experience with using DOACs in these patients with stents, and there are some registries collecting data, and she may be one to add to a registry. But yeah, thank you. That was a very interesting case, and good luck with the rest of your training.
Thank you.
Okay, thanks very much to both of the presenters. We know it's not an easy thing to do to come onto this kind of meeting when you see the number of participants that we have and present. So that was well done to both of you. And yeah, we hope the beginning of a future career in thrombosis for both of you.
Thank you for allowing me to participate.
No problem. So we're just going to break for a few minutes now while the panelists have a quick discussion about the two cases. And in that time, Will is going to lead some discussion. I think we have had lots of queries that have come through in the chat box, so hopefully there should be plenty of things to discuss. So I will turn my off while we have a separate discussion, and then we'll be back with you soon. And I'll pass you over to Will.
Thanks, Jill. So yeah, I think now while the judges are deliberating, it's a good opportunity to ask any of those burning questions that you haven't already asked. So you could either, it's going to be harder to see people's hands raised, so it would be better if you can either put something on the Q&A or on the chat. We've actually got a question there. Can we use, I've got some actually, let's have a look. Can we use D-dimers to differentiate acute on chronic thrombosis from chronic thrombosis? That's a good question. I'll give a verbal for that one. So it depends what you mean by chronic thrombosis. If someone has got residual vein obstruction, so they've had a DVT, say 6 months ago, and they've got some residual filling defects on scanning, then in theory, that in itself isn't going to impact on the D-dimer, because the D-dimer in principle should be a measure of acute thrombosis and not old scarring, basically, from a previous DVT. So a D-dimer, which is elevated, is obviously a little more suspicious. You would expect that the presence of residual vein obstruction or some chronic old scar tissue would not give you a positive D-dimer. Now, saying that, forget whether it's chronic or acute, everybody runs a different D-dimer. Some people run naturally a D-dimer above the quoted normal range. So when we say what's normal for D-dimer in a non-thrombotic person, we take a whole load of people and we measure their levels and we say, okay, this is the sort of range of normality. But some people intrinsically run higher D-dimers above the normal quoted range for whatever test that you're using. And we do know for those people who have had their period of treatment, so if they've had 3 or 6 months of anticoagulation following a provoked or unprovoked event, although we use it more for unprovoked, when you stop anticoagulation, a certain proportion of people will then go back to their baseline D-dimer, which is abnormal, which is raised. And we know from studies dating right back to the first Italian study that was done on this subject, where they stop people's warfarin and then they check their D-dimer a month later. We know that some people will have a raised resting D-dimer when they've completed their anticoagulation, and those people have a higher risk of relapse, a higher risk of recurrence. So so I guess to summarize, having chronic scar tissue from an original thrombus should not in itself necessarily influence your D-dimer. But people run different D-dimers, and some people run higher D-dimers, and those people are you should identify as having a higher risk of recurrent thrombosis. And you might say, well, this is quite useful information. When's it going to be useful to me? Well, for some patients, you don't need to bother with a D-dimer because they've had an unprovoked pulmonary embolism at the age of 20-something. We know that their risk of relapse is going to be 40% over the next 5 to 10 years at least, as an average ballpark figure. You don't need a D-dimer to tell those people that their risk of recurrence is high. But there might be someone where there's a bit of uncertainty. You're sitting with a patient, you're not entirely convinced that lifelong anticoagulation is justified. They're not entirely convinced that lifelong anticoagulation is justified. You're on that sort of equipoise. that might be a time when a D-dimer is useful. So you could stop your anticoagulation, check your D-dimer, and if it's raised, it's going to push you more towards a yes. I think this person's more at risk. And if it's normal, it doesn't mean that that person will never get a thrombosis. It just means that it's a little more reassuring. Some people, and I certainly do it myself, in some individuals, will check a D-dimer on anticoagulation. If it's abnormal on anticoagulation, that's almost certainly a predictor of a high risk of relapse. So you don't even need to think about necessarily stopping it. So hopefully I've over answered that question. Pending, has anyone else got a question?
I'd just like to add that we don't use D-dimers in pregnancy because the variability is so high. And they tend to be elevated in pregnancy anyway. So we really haven't used D-dimers in pregnancy.
Okay, I mean, it's a good point. I mean, this is always the problem with a D-dimer is it's sensitive. It's reasonably sensitive to nucleot, but it's not very specific. So lots of things cause your D-dimer to go up. There was a lot of interest with COVID pneumonia, measuring people's D-dimers when they came in. It caused all sorts of chaos and people were trying to anticoagulate based on D-dimers alone. That whole story is sort of closed now. We should not really be using D-dimers to determine management in COVID pneumonia, just as an aside.
So the very last thing that we're going to do is just talk through the judging of the case presentations. They were both excellent. As I said, we appreciate that it takes quite a lot of confidence to come and do that to this sort of audience. We hope we've shown you that we're quite a gentle crowd as thrombosis doctors. We're non-malignant by name and nature, hopefully. So we'd actually like to award both of the presentations with a certificate to say you've presented and to acknowledge your contribution. And Jo is going to organise, with your permission, for your recordings to go on the Thrombosis UK website and to do some publicity about this event and the fact that you presented. So we hope that those things will be helpful to you in your career and that this will fuel similar further presentations. So if there are no other final closing comments, I'd like to thank Jo again. I've really enjoyed planning this and running it. Thanks very much to all of the speakers. It's been fantastic. I think we've had a great balance and we've represented the whole field of thrombosis pretty well in 2 hours, I think. So enjoy the rest of the meeting and we hope to see you all again at some point soon. Thanks very much.